I can see that a few people are in the audience. Would you mind just briefly introducing yourself and the background?
Sure.
And also your team member who is unable to
Sure.
connect. Yeah.
Swaramya, if you can hear us, please join. I think your audio is working because it is in our best interest to start. So in the meanwhile, yeah, so my name is Max Kushnir. Hi, everyone. I'm a biologist by training. I'm one of the co-founders of a healthcare startup called Sova Health. What we do is yes, it works.
Hey.
Good for us. Hey, Swaramya. Of a healthcare startup called Sova Health. What we do is we use nutrition to help our patients to manage or prevent chronic disease. We are a company that's based out of Singapore, but we mainly operate in India as of now. And with us is Dr. Swaramya Chandrasekaran. Yes, nailed it. And Dr. Chandrasekaran is a gynecologist. Hey, Natalie.
Hello.
Okay. Is a gynecologist, and she specializes on treating patients with PCOD and PCOS. And Swaramya, I'll let you talk a bit more about yourself before we start.
Hi, thank you, Max, for the introduction. It's lovely to join all of you this morning. To start off with, I must say what Max and Tanveer have started in Sova Health is a very important component in clinical care for me. So what I predominantly deal with in my practice is obstetrics and gynecology. My special focus of interest is adolescent endocrinology, which encompasses a major component of polycystic ovarian syndrome because it's a spectrum of diseases, metabolic diseases, which start right at the onset of puberty. Now studies say they're much earlier in life and probably even in in utero environment. So that's specifically my focus. And like all research ultimately tells us, it's only about lifestyle modification, getting your diet right and getting in some component of exercise. So I think we'll probably have a good conversation over how important it is to us.
Yeah, definitely. Yeah, so let's just kick off. There are 3 or 4 main points I'd like to address today in this discussion. I'm happy for others, of course, to join in. So metabolic disease in general, and specifically these 4 use cases, are a huge problem around the world, and India is a good lakmus for the rest of APAC as well. So diabetes-wise, out of 1.2 billion people, at least official population, 400 million in India are either pre-diabetic or diabetic. 10 to 15% is the statistics of women in reproductive age suffer from some form of PCOD or PCOS. Fatty liver disease, non-alcoholic fatty liver disease is around 10% or up until 32% in the cities, right? And heart disease is the second leading cause of mortality. So these numbers are quite shocking, and there's a lot of people in India suffering from these diseases, but I don't think there's any one reason we can point to and say, okay, this is why, right? So like with any condition, this is a mix of genetics and environment. And I think in India, yes, there is a genetic background that plays a role as well, but environment is something that we can deal with, right? Therefore, it is extremely important to understand how the environment is causing these diseases and what can we alter about it, right? And this is something I think that clinicians could use some help with, right? Because once the patient is leaving a doctor's clinic, the doctor has no idea what this patient is doing at home. And the sad reality is that these diseases, they're not, it's not like a lightning strikes you one day and you get diabetes or PCOD. These diseases are mainly the result of millions and millions and millions of small, poor choices that a person makes every day around their nutrition and lifestyle. It could be a portion that's a bit large. It could be that extra dessert. It could be that very late dinner, right? And it accumulates little by little. It's like a tooth that you're shaking, and finally you lose it, right? You lose control over your blood sugar, or your liver is damaged beyond repair, or because you are already hormonally prone to these diseases, like in the case of PCOD, right? These ladies are at much higher risk for developing metabolic disease. Therefore, they get sick. And it's very important to, like, the doctor's job, like, I don't think anybody is arguing that doctors are obsolete. On the contrary, the doctor's job is extremely important in dealing with these diseases, both in the community and both, of course, with medication. But I don't think it is, and I think, Swaramya, you can comment here, it's in the doctor's capacity or knowledge to go and give nutritional advice, right? Right? And of course, it is definitely not in the doctor's capacity to be there with the patient 24/7, right? To encourage compliance to whatever the doctor has ordered. So there's a big gap, right? Basically, what I'm trying to say in very simple words is that the patient throughout his life is making choices that are not, the doctors are not aware of or can control, and those choices are making this person sick. And this is when the doctor kind of sees the person, right? Because nobody goes to the doctors when they're not sick. I don't think anyone goes to the doctor and says, "Hey, doctor, I don't want to get sick. Please tell me what to do today, because in 25 years I might get diabetes." That just doesn't happen, right? So what we want to start doing is helping people. First of all, that we do at Sova Health is helping people first identify those diseases, because, for example, diabetes and fatty liver disease, they have no symptoms in the early stages. You just don't know, right? So usually people find out with a routine blood test. So we want to help them, first of all, find out, make them informed about their condition, and of course, prevent it. Or we want to get the patient that already has a diagnosis, and help them manage this disease at home, manage the choices that they're doing at home that is driving the result I'm seeing on their blood tests. And we think we can be a great collaborative tool for doctors to close this gap and work together with them, and in order to mend these diseases as in a more kind of a polyclinic model, right? Where you don't only have a doctor, but you also have a nutritionist, a nutrition professional, potentially you have a fitness coach, and you have technology enabling all of this interaction and taking some of the more mundane tasks away from the doctor and coach and nutritionist, eventually becoming more and more autonomous, because this is how we're going to touch upon that, I guess, based on this call. But Swaramya, I'd like to give the mic to you. What do you think about what I just said? And maybe you can give some examples from your clinical experience about how this might be relevant for you as a physician.
Yep. Sorry to chime in, guys. We also have a question from the audience asking, what do you think about dietary intervention of a whole foods plant-based diet to reverse and prevent some of our leading causes of death, like heart disease, type 2 diabetes, and hypertension?
Okay. Very briefly, I think it's half and half between how you eat and when you eat, as to what you eat. And I think people kind of overlook that a bit, especially in our industry, right, which is food tech. We're all about food. Habits match more. Of course, foods that are whole and unprocessed, they are much more balanced. A very good example would just be brown rice, right? Brown rice has a glycemic index of, I think, below 50. White rice has a glycemic index of table sugar, right? So there's a huge, and people in APEC really love their white rice. And it's a leading cause of, right? I see some smiles. And it's a leading cause of diabetes, right? Both in China as well. It's because you're basically eating something that spikes your blood sugar over time. And as I say, diabetes is a result of many poor choices. So yes, whole foods is definitely part of the answer.
Yep, and before we jump back to Swaramya, we have another question asking whether diet can be used to treat anemia.
Yes.
Yep.
Easy. Depends on the anemia. Of course, if the anemia is caused by bleeding, then probably no. But if it's the classical anemias that we're seeing, be it because of an iron or a vitamin B12 deficiency, this is something we commonly see in our patients in India, and this is something that we commonly treat with nutrition or supplements. In the case, you have many vegetarian people in India, and B12 only comes from animals, so there's a bit of a discrepancy there. But yeah, definitely. Swaramya.
Probably a few minutes, I'll take it from here. Now, like as Max pointed out very, very accurately, there are many gates that we have to cross as clinicians in an OPD. And I think all of this predates back to our medical training. How much of nutrition are we really focusing on, right? How to exactly prescribe a diet to a patient. Is that something that we have either as an elective or some sort of formal introduction or training to how diet has to be scientifically managed? It's not a very important core part of the medical training system, the educational system. So right there, probably we become less entitled to claim that, yes, we're very good at counseling what the right way to eat is. Okay. So the second bit, it's not just the know-how. It's about now when I sit in OPD, let's assume you have 10 patients spread over 2 hours. You have about 10 minutes to 15 minutes at max with a patient. Now, how are we going to decide to split that time in terms of, am I going to medically evaluate this patient? Or am I going to spend more time counseling? So counseling becomes a very important part of dietetic management. And you probably go through a lot of medical literature in your textbooks. So the first thing they tell you for diseases like polycystic ovarian syndrome, there is no absolute medical treatment for giving you long-term sustainable relief from irregular periods, from infertility, from subsequent diabetes, obesity, hypertension, heart disease. So what is going to give you the permanent cure? Lifestyle management. So what do I tell my patients in OPD? Listen, I've examined you. I've come to a diagnosis that you probably have a metabolic condition. And what's the first line of treatment? Dietary management. And do I have the know-how to tell you how to eat right? Not too much, because I think nutrition is a specific field on its own, right? Do I have the time to tell you what to do? Not exactly. I have 10 more patients waiting in my OPD. Do I have the ability to culturally connect with you, know what you eat, where you come from? Do I have the ability to tell you to eat according to your local custom traditions, what food you're used to in general? No. So there's also sort of a cultural disconnect for me. Then do I have the ability or the wherewithal to follow you up long term? It's not a cross-sectional intervention. You don't tell your patients, listen, I know Indians, South Indians, you're rice eaters, cut rice from your diet, probably cut sugar from, would say, why don't you get more wheat into your diet? Have you tried quinoa? I mean, these are like random things that people would suggest, but that's not how it works. I want patients to stick to diet as a form of medical nutrition therapy, right? So it's not just dieting, basically. So that sort of cultural connect is extraordinarily important, and I need longitudinal follow-up and not mere wish-wash talk. So are you eating right? Are you losing weight? How am I going to follow up as to what sort of biochemical parameters response are there in my patients? So have I reached my endpoint? You came to me with irregular periods. Did you regularize? Your diet and medical nutrition therapy is not working, or have you not been doing it right? Tell you why my to diet would probably be because they're not doing it right. And it's not about the as much as the intent that we do not want to do it, but rather we don't have the right tools to execute it and follow up. So that's where I think you fill in a very, very important gap. So
Thank you, Swaramya.
yeah.
So what health comes in.
No, I mean, just for the audience to know, Swaramya and us, we don't yet work together. So just so you know, it's a genuine confession from a genuine doctor you're witnessing here. But yeah, I think when we were starting the company, we started thinking about compliance, as you've mentioned, and there's so many different layers to compliance. I actually remember somebody having a very popular LinkedIn post saying, Indians, they're lazy. They just don't want to, to change their lifestyle. They like their ghee, they like their rice, they like this. And I was like, I don't believe that. And the experience of the past year has proven it. People want to get healthy. Nobody wants to get sick, especially with diseases like diabetes, which has horrible complications. And people see it all around them in India. So they know it very well, what happens to people who have diabetes, but they just don't know where to start. Like, okay, where do I get this quinoa, right? Or somebody came to me and told me, I was, and he was from Chennai, I think, not very far away from it, and said I was recommended Atlantic salmon. I'm like, okay, are you gonna fly it every day from Norway? I mean, and the Indian diet definitely has all of the components to be wholesome and healthy. It's just most people in India, I don't have data on that, please don't catch my word, but a lot of people in India, they're eating it wrong, right? They're having very late dinners. They're like things that you can possibly change. And one of the offerings of us as a company is you can fix your health and diet with the food you're already eating at home. And that is something that's blowing people's mind up, because then they said, okay, because a lot of people, they're not doing that. There are a bunch of diabetes management companies out there using keto diets as their kind of go-to, which is extremely effective. I cannot argue about blood sugar reduction and keto diets, and there's no sugar in the blood, right? It's all ketones. But people don't kind of want to follow that for more than the 2 or 3 months of the program, and then they drop back off. So what we do at Sova Health is we actually take the time to understand what the patient is eating at home on an item basis. We take extremely detailed food logs throughout the program that never stops. And then we have a nutritionist or algorithms, and I'll talk a bit about that going forward, to start suggesting interventions that actually make sense for this user, right? You cannot even treat a young student and a person that lives in an extended family and already has a family of its own equally, right? It's about geography. It's about religion, right? You have Jains. Jains don't eat anything that grows underground. I was mind blown when I found out, right? No potatoes, no onions. Like, why? Right? So there's so many different varieties of people and habits and religion and lifestyle, right? Students, they're skipping breakfast left and right. People who have families, their dinner is super late because, all the family, they eat together. So, okay, right? So there was a seminal study from Cornell in 2013 that found an average person makes, on average, 200 different decisions around food every day. Every day, think about it. Everyone here is making 200 different decisions about food. It's not only what's for lunch, what's for breakfast, and what's for dinner. It's what is the macronutrient composition of my meal? What is the glycemic index? What's the glycemic load? Am I eating right? Am I chewing fast? Like, all of what I'm just telling you is something that we are able to capture and actually start suggesting interventions for the patient that make sense for the patient. We work as a team. We say, okay, these are the 60 things you can do. Let's focus on the next 5 for the next 10 or 15 days. Tell me which of the 5 are making the most sense for you. Here's the most high impact recommendations or interventions. Let's agree together. And of course, once you're on a program, this also provides accountability, because you're going to be seeing somebody every 10 days. There's going to be everyday communication, right? So on average, our users communicate with our with our nutrition team 26 times per day. Per day, there's an exchange, right? Because they're telling them what to eat. Oh, I'm going to my aunt. I don't want to really insult her. What should I eat? Here's a picture of a table. This is how we work, right? So you have this. By the end of the program, my patients, they laugh. They say, I became a mini nutritionist. I can now make my friends, they ask me, what should I eat now? because it's not a course or a curriculum in a university we're on, but we actually provide very relevant information for what is happening for every person. We literally tailor it. And now, little by little, now we're starting to use technology to actually power some of those recommendations, right? So for example, people get a macronutrient report every day for them to understand how their macros been done per meal, because the one single purpose of our program is to teach a person how to have a balanced meal. Everything else comes out of that. Just every meal should be balanced and on time, potentially, ideally, right? And then out of that, your blood sugar is going to drop, your PCOD symptoms are going to alleviate, because there's a direct connection between blood sugar and the severity of symptoms, right? As a diabetic, of course, you're going to manage your blood sugar. As a fatty liver patient, you're going to put your liver in a 5-star hotel, say, hey, liver, you chill here, you relax, it's going to be okay. We're going to check the parameters in 3 months. And of course, we do regular testing on the program as well to make sense that, to make sure that the recommendations are actually working, right? A lot of people with deficiencies or anemias, as somebody mentioned here, I want to know that this anemia is subsiding when I'm prescribing food or supplements. We've had a patient over 50 years old that his anemia wasn't subsiding, and then we had to send him to the doctor to understand, okay, why is it not subsiding, right? Do you need a colonoscopy? Do we need to start searching, for other probable reasons of this anemia? So there's very little room for guesswork. And there are periodical check-ins that provide accountability. I think it's extremely important for some people, for a lot of people, to know that, okay, somebody's going to be checking this, somebody's going to, somebody cares. I'd better do right. But compliance-wise, we always say we never recommend anything that you can't do for the rest of your life. This is how we see it, because from the human element, right, from the compliance element, it's extremely important that that people are able to persevere on their own, and this becomes a habit and not a chore. And so far, we've been seeing good results with that, both on the clinical parameters and reduction of medicine, for example, but also on the compliance side. We have relatively high engagement and compliance rates, and also high referral rates. So that's good. It means something is working out. Yeah, I think if there could be more questions from the audience, that would be a good opportunity now for us to. I see somebody saying eating geographically. Yes, definitely. Yeah, that wasn't a question, actually. Swaramya, would you like to give an example, perhaps, maybe a specific one of how nutrition helped treat PCOD and PCOS in your patients?
Yeah, so for example, now subset of patients I treat come with fertility-related issues. So I have a 30-year-old who has a BMI of 29, been married for 5 years. She's undergone a lot of treatment in peripheral hospitals, procedures what we call ovulation induction, drugs to induce egg release, and then plan a pregnancy and IUI, and 6 of those procedures failed. Then she underwent a laparoscopy to make sure her uterus is fine, her tubes are fine, her ovaries are fine. And then they tell her she's to undergo an in vitro fertilization, IVF pregnancy. And then she finally comes to me. And you look at her, okay? There's a glaring problem there. And what is the problem? It's obesity. And now how do we tackle obesity? Infertility is an outcome of that obesity, of poor lifestyle choices. So now are we going to address the problem and let infertility take care of itself? Or are we going to ignore the component of obesity and get her pregnant? What happens after the pregnancy? How healthy is the pregnancy going to be? How healthy is the woman going to be? The baby going to be? How is the delivery outcome going to be? A mother is obese, she has a higher risk of diabetes in pregnancy, then the baby is exposed to that sort of a metabolic environment right from the in utero phase. And that has an impact on the health of the baby 10 years from now, 15 years from when it's born. So all we did was tell her, yes, I can understand your cultural compulsion to become pregnant. It probably your family is quite a bit in a hurry that you become pregnant soon. But before you give IVF a shot, why don't we let lifestyle intervention take its course for at least the next 3 to 6 months? Now, very few women would take up that option, but I'm really happy that the patient took up that option. She uh, well, it took a long time for me to counsel her about diet, and she went all over the place. It was COVID time, so direct access to my nutritionist in the OPD was restricted. But she figured her way out because she was smart, and she was lucky to have got the right sort of guidance. But I didn't have an opportunity to follow up and see how she was doing, whether she's able to sustain it. But she did come back pregnant, and that by itself, that sort of lifestyle intervention, diet control, and the effort that she put in that worked for her, that by itself was a victory for me, and helped me convert a high risk pregnancy into a low risk pregnancy from an obstetrician's point of view.
Great. Thank you. We have a question from the audience asking how many meals per day would you recommend? And all of us must have heard about intermittent fasting and having early dinner, catching fire. Which reduces the number of meals of a day to 2. What would be the comment on that? How can we address?
I actually have to comment.
Yep.
Yeah, quite a bit of our patients are asking this question exactly. What about this or that fad diet that's going around? The answer is very simple. First of all, could you, sir, do that for the rest of your life? If yes, then we can talk. Most people say no, because it's hard, right, to only eat 2 meals a day and be hungry. The science on intermittent fasting is actually mixed. There are certain kinds of intermittent fasting that has been proven. There was a big Lancet paper a few years back that was proven to have very good effects on cholesterol and blood sugar, etc. There was also a study by an American cardiologist, I really can't remember the name right now, one of the forefathers of intermittent fasting, that found intermittent fasting was as effective as a balanced Mediterranean diet with some calorie reduction in losing weight. But this weight, the weight that was lost was predominantly lost from muscle mass rather than from fat. And the reason for that is actually very simple. People who do IF usually skip breakfast. They don't skip dinner, they skip breakfast because it's socially acceptable to be having dinner, and breakfast is something that we kind of want to skip, right? Breakfast is a chore. But the fact of the matter is, what happens physiologically is that our physiology, our circadian rhythms, right, are telling us to eat more in the morning and less in the evening. And so what happens pretty much, I'm just going to very briefly touch the technical stuff. What happens during the night is that the liver uses a lot of the glucose that's stored inside of it to power the maintenance functions of the body, right? For the heart to pump the blood, for the lungs to breathe, for the brain to dream, etc. And we wake up empty, right? So there's no glycogen anymore. There's no sugar, and we wake up empty, and our body needs sugar. Breakfast is breaking fast, right? That's exactly what it is. You've been fasting, you have to break the fast. And what happens when you skip breakfast is the body turns to the next available energy source, which is actually not fat, it's muscle. For the body to start burning fat, there needs to be a metabolic switch, and this metabolic switch takes too long, right? It's not a matter of hours, it's a matter of a couple of days, as people doing keto will know, right? To effectively start burning fat for the energy consumption. Some of it also happens, but so people just eat up their own muscle, right? There's a catabolic activity that's happening in your body every morning. So, and by muscle mass, I don't only mean just your muscles, right? I also mean the lining of your heart, your smooth muscle, the lining of your blood vessels, your heart, your organs, right? So it's not a very good idea physiologically to do the kind of IF that doesn't include breakfast. The kind of IF that does include breakfast is actually proven to be a good idea because it's in line with the natural circadian rhythm of the person, right? So having your dinner very early. So some of it may be true, right? So there's not a simple answer on a complicated subject. I do think that having balanced meals is more important because even if you're doing intermittent fasting and you're consuming your calories in 1 meal per day, think about it. You're going to consume 2,000 because there's no caloric restriction in IF, right? Not officially, at least. So you're going to have 1 meal per day that has 2,000 calories. What's going to happen to your blood sugar then, right? What's gonna happen to the absorption of the different nutrients that you need to absorb from your food, right? Your food goes through your body in 4 hours. That's it, done. Does your body have the capacity to process all the nutrients you need per day in, this 1 meal? I'm making it extreme on purpose. Probably not. Probably not, right? So this restricted eating window, it has some downsides as well, right? So it's and the Lancet study, Lancet is the most respectable medical journal in the world, right? But these guys were looking at certain parameters, at many parameters, at many biomarkers. Look at cholesterol and blood sugar and all-cause mortality even. But it's still looking for the keyhole, right? Where they're looking at vitamin levels, some, right? So I don't think, I think it's a great idea to have a larger breakfast and to have a smaller dinner physiologically. I'm not sure if IF would be my choice. For managing chronic disease, intermittent fasting, I don't think it's very well accustomed for a diabetic, for example, right? Diabetics have to control their blood sugar throughout the day. And what we do is we start, actually they eat 5 or 6 or 7 or 8 meals per day on our program, depends on the person, right? And a meal could be a healthy snack as well, because we just want to stagger the glucose levels in the blood, right? We want to give it like a little every time, so that intake-wise, the body is not strained. It's like you're being very weak and you're asked to lift something very heavy at once, right? And instead of lifting something very heavy at once, we just want you to lift that in parts, right? We provide these pulleys, or I don't know what you might call it, right? So that the body doesn't strain itself, because the body is already having trouble to balance the sugar. Yeah, that's the thesis on it.
Add something in here. What you mentioned about spacing out meals and having it in short interims is extraordinarily important, because that's something I want to bring to attention, specifically in gestational diabetes.
Also,
right? Yeah. Extraordinarily important, because when my patients come with high sugars in pregnancy, the first thing that I tell them, please take 2 weeks out to figure out your diet. Exercise is not something that we can easily institute in pregnancy, because the patient has to probably continue to stay at the same baseline of exercise level that she was following pre-pregnancy, so that we don't introduce anything drastic and new during the course of pregnancy. So the only tool that I'm left with in terms of a scientific intervention is diet. And I have 2 weeks for that diet to take effect, right? Either the diet works, or I'm left with only the choice of insulin. And the best way, when the whole glucose metabolism is sort of on a high-strung mode during pregnancy, the best way that I can tell my patients, see, you can probably address your sugars with diet by taking adequately sized, not necessarily small, appropriately sized portions at appropriate intervals. Now, that is something that needs to be scientifically addressed, not something that you can just pull out of the air and say, I'm going to eat 1 cup of rice and 1 cup of vegetable and a few biscuits every 2 hours. That's not how it works, because your insulin levels and your sugar levels vary throughout the day, vary with activity, are different during the morning hours, different during the evening hours. So what you mentioned there is an extraordinarily important component, which can potentially help me in avoiding insulin administration during pregnancy.
I think you've mentioned in one of our previous calls that 50% of gestational diabetes cases turn out to be chronic diabetes, type 2 diabetes for life. Is that correct? And yeah.
Yeah, that's right. And gestational diabetes within 5 years has a 50% conversion rate into type 2 diabetes, which is much higher in the Indian subcontinent. Technically, again, because, even after delivery, culturally, we tell women, eat a lot, you need to get enough calories to feed, but that eat a lot has to be eat right? And that, again, accelerates the progression to type 2 diabetes.
Yeah. I think there's another question from the audience about plant-based nutrition.
Let me see. I think, yeah, the question really is around if, I think the issue with the diet centered around a whole food plant-based diet could reverse, you know, the #1 killer, heart disease. Shouldn't be the default diet. I think touches upon facts that you guys mentioned before around culture and what you're used to, and the sort of the high habits that you usually have. And it's been proven, yes, that plant-based is more sustainable, healthier with certain aspects, but how easy it is to transition and incorporate that in your actual real life, and take a practical approach to it. I don't know, like, I think that sort of is the crux of the issue.
It's actually very easy. Most of the Indian diet is plant-based whole food diets. Like if you go out of the city for a moment, like India is home to thousands of superfoods. You have ragi, right? All of the different millets that these guys are having in the, and you also see, it's actually very interesting in India. All of India suffers from metabolic disease, but the types of metabolic disease urban Indians suffer from, and the types of metabolic disease the people living in the villages suffer from, right, are completely different. So in the cities, you'd see people overeating, overindulging, right? And you get all the heart disease and the other problems that we hear about. In the villages, anemia is extremely prevalent, right? Anemia on the pernicious anemia, right? The B12 type of anemia, right? Because these people undereat. But in any case, they have extremely good sources and to balance the diet out. The Indian diet by nature is unbalanced. It tends more towards the carb and very, very, very little fiber, which is one of the big causes I'm seeing for why India is so diabetic, because these guys are just having many, even a normal Indian thali has a high glycemic load, right? Because there's very little protein. It only comes from the legume, and the legume is like 20-30% protein max, right? And everything else is carb, and there's no fiber. And all the vegetables are cooked to death, right? So add a salad to that, and you're good to go. Seriously, add a salad, 20 minutes. Like one of our most impactful recommendations at Sova Health is add a salad to your lunch and your dinner 20 minutes before you actually have the dinner, right? Because the fiber will be already there waiting. The satiety factor, right, from the mechanical pressure on your stomach is higher, so you don't overeat. And whatever you do eat doesn't spike your blood sugar. Same food. I haven't taken anything away. With regards to plant-based, most of Indian ingredients, like what goes into the thali, is actually healthy, and or can be healthified at least, right? And this is one example. So yeah, I think India is a great example of a local plant-based diet that can succeed. Most Indian being lacto-vegetarians, the component of the lacto-vegetarianism can usually be balanced a bit, right? Not everything should swim in very heavy sauce full of refined butter or having very high fat milk. But most people don't do that, right? Most people they just eat normal food, good food. It's just the timings that are off, or the way they eat it that is off, or the portion sizes are off, or the plate structure, right? You have this beautiful plate system from Harvard in the 80s. This guy's devised, right? Some part of your plate has to be carbs, some part of your plate has to be fish. I think everybody here is familiar with that. Well, it's not a big thing in India, sadly. And this is something that we're trying to kind of bring along more, so that people kind of more become aware, right? Where is what coming from, right? So people are sure that when they're having their dal or their legume and their pulses, it's full of protein. But do you know what's the percentage? Like the highest, popularly used legume for protein is chickpeas. The percentage of protein in chickpeas is just below 20%. Everything else is carb or fiber, right? So when you're eating chickpeas, you should eat more of the chickpeas and less of the rice. There's no need for a side dish. Like that's what you do, right? So no, of course, carbs are just for everyone here. Carbs are an extremely important part of our diet. 50 to 55% of our mainly calories for most people, not for all people, most people should come from carbs. No doubt, people are going low carb. They're saying, no, I'm going to cut in carb. I'm doing this, I'm doing that. You're shooting yourself in the foot. You need the energy. But the way we consume the carb has to be smart, right? The carb has to be complex. The carb might contain also, some other nutrients that are coming in with it. Just throwing out whole food groups from your diet is not going to lead you to a very good place, because when you give up the calories, you also give up some nutrients that your body needs, right? It's food you're giving up. It's not just this or that. And people tend to kind of look for very simple answers for questions that are in nature quite complex. And I think there's a huge information gap, because there's so much information online, right? And everybody's kind of Googling and so, I Google this and I Google that. That's pretty much half of my day. I Google this and I Google that. Well, but this is why tools like Sova are very, very important. And as I said, as time goes by, and already today, some of the functions, for example, some of the recommendations of where should my fiber come from. So we had a patient that, we had many, but one patient had a deficiency in fiber for consecutive 5 or 6 days. We saw this in the macronutrient reports that we share every day, right? So we said, okay, so there's no fiber at dinner. Why is there no fiber at dinner? Here's what you can do, right? So our system is now able to find, and here are 10 foods that have fiber. Which 3 do you like? Right? And this is something that usually would be done by the nutritionist, but can definitely be automated. And there's already so much value there for a person, right? And the technology can power something like this. It already becomes amazing. In India, at being as an Indian company, we are an Indian company, so we understand that the only way this can go into the mass market and a large amount of people can enjoy this and benefit from this is not going to be through us giving the best counseling we can. It's going to be through a DIY version that's going to do 20% of what we're doing, but those 20% are definitely going to bring like 80% or more of the value, right? Because if a person can just log their food and can start seeing, okay, this is where I am and this is what I need, and everything there is healthy, everything that is curated, there's trust, right? Then the cultural barriers that Swaramya was mentioning can be overcome. The preference barriers could be overcome, right? Because I could just give you a list of 20 options. You can choose the 3 you like, or you have available, or
gives you the ability to scale. Yeah,
exactly. So already there's a lot of value, right? Because it's very good to learn, and as a scientist, I really like data, but my partners keep reminding me that, hey, Max, this also has to be actionable. Right? What do I do with this data? Data is not the goal. So things like that would probably be a good example.
I 100% agree. I think people have goals, but the trick is in making it easily adaptable to their life.
Exactly.
And scalable. No, I mean, thank you. I thank you for this conversation. I mean, I personally also learned so much. I think PCOS is something so common that people don't really talk about, and that only recently me and like a lot of my girlfriends around our age as well learned that it can be managed through diet rather than medication and all of these things. So really believe that it's the stemming factor. Did you want to say something, Max?
A lot of people are coming and saying exactly what you're saying, Natalie.
Yeah.
I'm here to manage my diabetes without medication. I'm here to manage. No, we're parallel to medication. If we have the same effect as medication would have for most people, or right? This is, as Swaramya said, this is the first line treatment. It doesn't mean it's the only one, and it doesn't mean it can swap one another. Okay, that's a very important. Like, there's no simple answers to complicated questions. There's only complicated answers.
That's absolutely right, Max. What I'd like to add here is diet or nutrition, what we call medical nutrition therapy, can be a primary therapeutic option, or it can be an adjunct to ongoing medical management. So the value is immense, whether as a single intervention or in conjunction with my medicines, it probably helps me decrease the dosage of my medications.
Yep.
Another point that I'd like to add is like in younger women with significant probably social media pressure and the pressure to look skinny, right? So I get a lot of girls with malnutrition, not necessarily anemia, multiple deficiencies. But I think this is where we can add value even to the adolescent and young population, that the right diet choice is also going to help you reach the right body type. So it's not only treating diseases, it's about teaching them to eat right and reach their target goals. It could be weight, it could be appearance, right?
Yeah, take care of their bodies.
Yeah, I mean,
It's
people
probably a
definitely
discussion
lose weight
all
on
the
our
time with
program.
my friends. Probably call my friend, I could be a doctor, but I'm like, I'm gaining weight. I probably look fat in this dress. I think I have to do something about my diet. And then what do I do next? And then
Send them over to me, of course. What do you mean, what do you do? There's a discount code somewhere here.
I think I'm as guilty as the patients that I keep talking about.
Yeah, we're not holier than the bunch. It's true. Yeah. So so in terms of taking medication versus nutrition, I just want to say, yes, we do have patients on the program that are going off their meds completely. Even some of them don't. But in any case, for all of these, so for every metabolic disease, be it because fatty liver, diabetes, heart disease, and PCOD, they're connected. It's malfunctions in the same system. It could be the endocrine axis that's malfunctioning, like in the kind of PCOD, right? The hormones are wonky, or are wonky, and right in diabetes, that's also a hormonal disease, right? In essence, or a response to a hormone disease, in essence, right? So it's the parts of the same system that are going faulty. And a lot of the times you see these guys come as a bouquet together, right? A lot of people have diabetes and hypertension, PCOD and diabetes, right? It's because it's the same system that's kind of going haywire. And just logically thinking, what you input in that system is what makes it to go haywire, right? So nutrition has extremely important role to play in all of these diseases, be it in management or in prevention. So if you're already sick and you want to go, it makes a lot of sense for a diabetic to get both. You can't only get medication, right? In some cases, you can only get nutrition. In some cases, you can't, but it's not interchangeable necessarily, right? For some people it is, for some people it isn't, but it's very relevant for all people that have these chronic diseases to mind their nutrition. That's going to give you the quality of life. That's going to, help you avoid the complications.
And you are what you eat.
You are what you eat. Oh, yeah.
Yeah. Anyway, well, I think, thank you very much for sharing your insights. I think we've run a little bit over, and it's definitely been a fascinating conversation for me. I'm going to be trying your salad tip. Eat your salad before lunch.
Yes, do. One takeaway from today: have your salad 20 minutes before your meal. Yeah. But don't make it a lettuce salad. Make it like a nice vegetable.
Like fiber. Okay.
Yeah, lettuce has very little fiber, surprisingly.
Okay. Yeah. Okay. I will definitely try that next week onwards. So anyway, thank you very much both for your time. I will. Thank you very much both for your time and for this conversation. I'll let you go as we've run over. And I think anybody who would want to get in touch, I think your contact details in the chat box.
Yeah. Okay.
Great. Thank you.
Thank you, everyone. Bye-bye.